We see you in all your glory, and we hear you the same.
Thank you very much. I want to thank, first of all, I want to thank you for inviting me back. And unfortunately, I had an interaction with the American healthcare system, which means I couldn't come. But I'm getting better, and that's a good sign, except I'm worried about my mental health because I was actually looking forward to John's jokes. And I was missing them in some form. Well, I thought I'd spend a little bit of time today, and I'm going to put a timer on so that at least the people who follow me can't complain that I took too much time away from their presentations, because I know you want to be able to be on time and hear everybody. I wanted to spend some time talking about the differences between percentages, absolute cell counts, things like that, that sometimes confuse people a lot. And so I think a fair amount of the hematologists here can probably take a nap for a little of it. Once we get past, I think it's the third slide, and then they can kind of nap. One of the first things I wanted to tell you was blood is not a liquid. It's like chicken soup. It's like, for me, clam chowder. It's a well-made salsa. There are solids in there that are suspended in a liquid. That means they're not dissolved in it. They remain, unless like my mother used to when she would overcook the chicken soup, and then the rice kind of mushed into everything. These are individual solids. You leave it alone in some kind of test tube or some kind of volume, the solids will separate from the liquid, and they'll do it based on their weight. Even though they're one of even though they're a smaller cell, as cells go, red cells contain hemoglobin, and that's a very heavy chemical to carry around with you. So the red cells will settle to the bottom. And then as this, I'm hoping that this pointer will work, this white area of white blood cells is actually a combination of white blood cells and platelets.
We do not, excuse me, Susan, we don't see your slides. And I don't know if that's something our IT people can fix, or if you need to hit share.
I don't know, hang on for a minute. I thought I had done that, but we will go back and see.
You don't look sick, though. You look very well.
Well, that's because my host has disabled my screen sharing. So you guys have to put it up on your own, or give me host access.
I see you try. Can you click on share screen again and see what happens?
Yep. Host disabled.
Do we need to do it? All right, we're going to get to it.
Okay.
This has happened to us even when we're here in real life. Where,
I know.
So it's okay.
Oh, there's a rule with any PowerPoint presentation. If you get there a half an hour early to make sure everything works, it does in the first 2 minutes, and you're sitting there twiddling your thumbs. If you get cocky and you walk in 5 minutes before the presentation, nothing works. So
do we want her to go ahead and share her screen? Yeah, go ahead and try it now.
Okay. Share. And let me put this on slideshow so it looks pretty. And we'll start from scratch all over again.
I'll give you another 30 seconds, so don't worry about it.
Yeah, right. Okay.
All right, so go ahead.
This is the title frame, and we can skip that and go to the next one, which is the chicken soup one. And again, the red cells are down here because they're heavy. This thing cheats. It says white cells. It's supposed to be white cells and platelets. And then you have the liquid, the thing that's got all the dissolved stuff. Glucose, BUN, creatinins, enzymes, electrolytes, all of that kinds of stuff is dissolved in this top level here. So chemistry people like the top level. Hematology people like the bottom level. This is the only slide the physicians in the room have to look at, and if they would stand and salute, that would be okay, because this is one of the first and most important things that ever happened in hematology in the 1930s. Max Wintrobe, whose book has been one of the Bibles of hematology since then, figured out that if you put this well-mixed blood into a tube that had been scored to 100 millimeters and just either let it go or centrifuged it, you could get a fact. You could get red cells down here occupying approximately 45% of the well-mixed blood. And you could look at this second one down here, and there's fewer cells. And then over here, there are greater cells. This is the macro hematocrit. At one point, it was the most accurate test in the clinical laboratory formulary. So that says something important about the hematocrit. And if you see this, you can see that it is all a real percentage. You've got the whole blood starts out here at the 100 millimeter mark, and things just fall or get centrifuged. Why do I care? The liquid is important for a couple of reasons. Yes, it has glucose, and yes, it has enzymes and electrolytes and all those other kinds of things. But one of the most important things that we tend to diminish, I guess, minimize, is that the liquid also keeps your blood tubing, excuse me, the arteries, the veins, the capillaries, it keeps them all open so that the volume of blood can move around. So the fact that you have plasma in a certain volume is an important concept. It keeps blood circulating. And the physicians who are now beginning to say, yeah, I learned that in medical school a while ago, are also saying that nobody cares, or very few people care. But I want to say something that says that this change in plasma is important, because you have a certain amount of blood volume, each one of us, somewhere between 5 and 7 liters, depending upon who you are. If you increase that plasma volume, like by an over-enthusiastic use of intravenous fluids, for example, since you're doing this on a percentage and that plasma volume has increased, your red cells counts, your white cell count, your platelet counts are going to decrease. If you have a decreased volume, dehydration, shock, hemorrhage, in the beginning stages, burns, probably one of the better examples, because when you get a burn, the blister that forms contains fluid, and that fluid that's in the blister is plasma that should be in the bloodstream. So you get a movement of plasma out into the blister, which means you have a decreased volume of fluids. Physicians tend to be nervous about this changes over time, because circulatory overload is dangerous, and so is circulatory collapse dangerous. So why is this important? Can we test for plasma volumes? Yeah. Yes, we can. We can even do it in dogs and in other mammals. Veterinary clinics will have that on their list. So, you know, if you really dislike your neighbor's dog, I suppose you could ask them to do this, because it requires a lot of work. It requires the use of radioactivity. It's a problem for a lot of people. So what does that mean? If I don't want to test the plasma volume, I am going to assume that it is normal. This may be a slight bugaboo for me, because during surgery, and I have the 2 reams of paper called my medical records to prove that it was an interesting surgery, I ended up with a circulatory overload. And so every lab test that came out for several days were off. And well, fortunately for the physicians, I was unconscious, so I wasn't yelling at them. But here's an example of what the difference is. If I take 3 teaspoons of sugar and I put them in an 8-ounce cup of tea, well, first of all, it's not going to get into solution at that level. I can measure that concentration, and I can measure it as a percentage if I want. But if I take that same 3 teaspoons of sugar and put it in a 12-ounce mug, even though the absolute amount of sugar that goes in is the same, I'm going to get a different percentage. I'm going to get a different volume because the overall volume of 12 ounces versus 6 ounces has changed. Does that make sense? One of the hard parts about Zoom is I never know if anyone is getting things or not getting things. So every now and then I might want you to, I don't know, throw something at the, no, that would damage the screen. Boo loudly if you don't get something. Because that way at least I know what's going on. At any rate, why is this important? Rumor hath it that some of you, particularly those of you with very small veins, decide that it's easier to increase your plasma volume because that will make your veins a little bit more noticeable to the phlebotomist. So you're down 1 or 2 liters worth of fluid before you go in for your blood test. Well, what have you done? You've increased your plasma volume. So let's say you're supposed to have 5 liters of blood and you just down 2 liters of fluid. Well, what have you done to the plasma volume? And the total volume, you've increased it. And if you increase it and the report is done in percentage, then things are going to be lower. Examples sometimes are horrible, but here you go. I had a normal platelet count going into surgery. As I say, things happened, like a lot of fluid was put in, and coming out of surgery the next day, I had 19,000 platelets. And the question of the day was that because somehow my platelets had shut down or I was bleeding somewhere? Or was it the 40 pounds of fluid that I had gained during surgery because of the fluid that they pushed in IV? So this is an important thing for physicians to understand. It's also important for patients to understand when they look at what I'm going to call patient preparation. You know, you have to be consistent in how you walk in to that phlebotomy collection area so that your physician will be sure that what is being compared from January 1st to February 1st are those 2 numbers. If they've changed because of something real and not just the fact that you down 2 liters of fluid beforehand. I hope that makes sense. And now I'm going to talk about something that again, I know that everybody gets somewhat confused about. Yes, I know there are 2 differentials on your CBC report. And we're going to talk about both of them. The original manual differential, the one we still use, the traditional manual differential, is to take a drop of blood, put it on a slide, and smear it as this cartoon kind of explains. Supposing I put twice as much blood on the slide. Supposing I put 1/2 the amount that I'm supposed to have on the slide. Will that interfere with the cells that I'm putting on the slide. If you look down here at the bottom, you can tell this one had much more blood than this one. You know, and the middle one is normal. Well, why do I care? I care because as I'm pushing blood across that slide, granulocytes and monos, like the edges, they are phagocytic cells. They're looking at the slide saying, well, no, this is foreign, and I actually think I have to eat this or somehow. So they will pick up on this top level slide as it moves across, and they will get to the edges of the smear because they're trying to eat the slide. You know, I mean, they're bright, but sometimes they make mistakes. And that's one of them. Lymphs don't care. You put lymphs anywhere and they will fall wherever they fall. And so you have a situation here where you have granulocytes and monos somewhere around here. You probably have lymphs scattered evenly somewhere across it. Where do I look? Can I look where it's too small or too thin? Can I look at it where it's too thick? Is there a difference? Well, if this is normal, I can see that the red cells have got pale centers. I can see platelets. And if I'm really good at doing this, I can see platelets with their granules in the middle and a little bit of outline on the side. Here's a poly. And yeah, maybe looking at that red cell a little hungrily, but another thing important. If I go to the very, very, very thin areas of the slide, the red cells look different. They look flat and squished and spread out. And if I look at it where it's too thick, well, everything's going to look round and dark. And we won't be able to see what the cells look like. So the object of the game is to go across and then across in this somewhat thicker area so that as I do this, I get to have a sense of both the edges and the middle. The rule is supposed to be, if the white count is less than 15, some places 20, it varies a lot. Count 100 cells, call it a percentage and move on. If it's a higher number, then maybe you should count 200 cells because you want a statistically reasonable population of cells. And if it's higher still, you may have to go 500 cells. Well, 500 takes longer than 100 cells. And while I absolutely agree with every single person in the room who just said, well, I don't care, I want you to take the time and count the 500 and make it real. Outside forces, let's put them that way, say you got to do things fast. You got to do things efficiently. You've got to do things at 6 Sigma and lean and whatever those things mean. So most places will just count to 100, convert it to a percentage and report it, unless it's very low. And then you might count 50 because it's hard to find the cells. And if it's less than 10, less than 1, which in some cases, when you're looking at someone who's got an aplasia or a drug-induced suppression of some sort, yeah, you can get that low. Well, then I'm just going to count 10, and I'm going to say in a note, this isn't a percentage. This is the best I could do. This is the number of cells I could find. Well, wait a minute. Let's go back here. That's pretty crummy. Because if we only count 100 cells, maybe we'll miss things. You know, that drop has probably got millions of cells in it. Maybe I'm pushing it. Let's say thousands of cells in it. And I'm only going to count 100 cells. The luck of the draw means that it is possible that we might miss something. It is also possible that we might find something. So when you are looking at your reports and you look at that manual differential and it says 1 metamyelocyte, yeah, I wouldn't really stress over that unless the next time you get a CBC, there are 2 metamyelocytes. Occasionally, 1 cell can be found, but as long as it's not consistent and as long as it's not progressively getting increased in number, then, you know, it can be just dumb luck that we found it. But everybody also should say to me, well, can't you count more? Wouldn't it be a better thing to count more cells? How about, is there something better to count? And we just happen to have this automated instrument. That's the differential with the ABS or the number sign. This is an absolute differential. And what happens here is really easy. There's no smearing. You put the red cells up in, the CBC, the whole blood into a chamber that gets, why is this doing this? Progressively thinner and thinner so that the cells line up 1 cell at a time. And if I've got detectors in the area where there is this 1 cell at a time flow, well, I can have a detector that's just looking for granules. They're counting neutrophils. I can have a detector that's just looking for lymphocytes or EOs. And because it's an instrument and it's doing these things single file, they can count many more cells than the manual differential. Some of them count as high as 50,000 cells. Some of them as low as 10,000 cells. Well, if your white count is, let's say, 11,000 for a white cell count, and I'm going to count 10,000 white cells, you can be pretty sure that what you see is what you get. You get a number that says, out of the 10,000 cells that I counted, 7,642 are granulocytes, and 2,608 are lymphocytes, and so on. This is an absolute count of what you've got. Does this give you any advantage over the differential? Oh my, yes. One of the hard things about a percentage is that it's sensitive to misinterpretation. This is a slide that shows you every single of these 3 people, they all have the same differential, 70%, 20%, and 10%. But if their white count varies, the absolute counts vary. So in this person, you might have maybe a minimum number of neutrophils, and yet 70 is an upper limit of a percentage. In this one, you might have a little bit, these reference ranges over here are just for examples. This guy's got a slightly increased neutrophil count. And this one has got a definitely increased neutrophil count, an essentially normal lymphocyte count, but also an increased monocyte count. So picture your poor physician, it's, I don't know, 3 o'clock in the morning, and it's been a really bad night in the ER, and they're looking at 5 or 6 patients' results, and they're all 70, 20s, and 10s, did the neutrophils go up? Did the lymphs go down? How do I interpret percentages? Well, nowadays I interpret percentages by looking at the absolutes. So which one's better? Well, the automated differential, trust me, I'm almost done. The automated differential is definitely better in accuracy. Why? Because it's counting considerably larger numbers of cells and it's doing them one at a time. It's also much better on reproducibility because it's an instrument. So it can go back and do the same test over and over again, where I, using a slide, might use one area of the slide for my first differential. Somebody else comes along, does a second differential. Oh, shush, that's my timer. And get a different answer. The manual differential, however, cannot be beat when you're looking at quality essentials. What do I mean? I mean that I look at your your white cells. So I look at red cells too, and I can kind of count the number of granules. And I know in the case of the neutrophils, whether you have more primary granules or less than you should. How many inflammasome areas might you have? How many vacuoles might you have? Things that automated instrument might not pick up. There are times when you sit there and say, I don't know, is that a band or a poly? I don't know, is that a band or a metamyelocyte? The instrument has predetermined algorithms, and that's what you're going to get all the time. Whereas I'm going to sit there and say, well, let's look at this. I want to look at what the nuclear pattern looks like. I want to know what the chromatin pattern looks like. I want to see about how mature the cytoplasm is, so I can make much more educated guesses about whether it's a poly or a band, whether it's a metamyelocyte or a myelocyte. Both of these differentials give you two types of reports. So what's the answer? Do them both. You know, if something happens, it's a change in the automated differential from the last time, request a manual. Because you will get then a more complete assessment of what those cells are like. If you know you have an unusual disorder that affects white cells, yeah, you don't actually want to even look at the manual differential unless you're talking about quality assessment. The automated differential will be easier for you to interpret. There. So why is it important that you know about this? Because some places in cost-cutting measures will not do a manual differential routinely. It has to be ordered. So you can request it. Your physician can request it. You can request to have both the automated one and the manual one. Typically nowadays, everybody does the automated one because, you know, you can get a turnaround time that's faster, obviously, because of the manual differential. Okay, I'm going to stop sharing and hope that A, I didn't cause everybody to go to sleep early in the morning, and B, not go too far over time. Are there any questions?
Susan, I can't tell you the beaming faces that are here in this auditorium listening to your talk. Everybody give her a round of applause. Simple but profound. So normally we would have everybody wait for our panel discussion, but in your case, we don't want you to have to wait around because we don't even know when our panel discussion will really occur. So
Right.
Let's take questions if there are any. Don't want to miss anybody. There's one here. I'll repeat it for you.
Okay.
Good question. The question is, are blasts only found when a manual differential, or can the machine detect and record blasts accurately?
Well, the important word in that question is accurately. Yes, certain instruments can detect blasts, but they have trouble a lot of times discriminating between large lymphocytes, which can have about the same size and about the same chromatin pattern. So yes, they can, although they sometimes have trouble. So in that instance, if you are concerned about it, or if you have a history of them, you might want that manual differential, because then you get somebody to actually look and say, ah, not a large lymph. Yes, it's a blast. Or no, it's not a blast. It's a large lymph.
And
They look a
because,
lot alike.
thank you. And because blasts are so important, for example, in the DIPSS score, even one blast is adds a point to your risk score and can mean the difference between whether you're being considered for a transplant or not. It
Yeah.
would be wise to make sure that a hematologist has, or at least a very good tech, has reviewed that smear manually. Yeah.
Yeah.
Another question over here.
Can you explain why you'll see blast in some labs and not the others? Over several different draws, how you can have blast and then zero blast?
So the question is, why do I have blasts on one day and then on another day I don't have blasts? Are they that mercurial and come and go, or is there something wrong with the testing?
I'm always going to have the asterisk about testing is not perfect, but yes, they are that mercurial. They are not modal in and of themselves. So if they get out from the bone marrow, it's because a mistake happened. So you have to have a blast that has somehow gotten close to an opening and has gone out in the rush of red cell release or granulocyte release. So yes, there are times that you can have one, and then the next time you can't. I'm always somewhat willing to forgive a bone marrow for one blast. Two, on the other hand, no, that's a meaningful statement, because one, you're putting out zillions, good scientific word. You're putting out zillions of cells twice a day. Are you going to tell me that every single one of those cells is absolutely perfect? So yeah, if I find one, obviously I note it. Obviously I think about it. Obviously your physician's going to notice it. But there's a world of difference between finding one and finding two, or finding one, the first CBC, and then some repeat CBC later, you get another one. That's a different story. Does that help?
Yes, she's nodding. Any other questions? If not, I'll let her ask a follow-up one. Yes, over here. Are there different ways to measure proteins in blood? What kind of proteins were you thinking of with that question? Yeah, so you get a chem group, it says protein, total protein, but then you might get a serum protein electrophoresis and it breaks it down.
Yeah, and the protein electrophoresis is worth 20 minutes on its own. What you do with the total protein is you take the serum, the plasma, you find out how many proteins are floating around in there. There are two basic kinds, albumin, globulins. So that's a total protein. You test for the albumin, you subtract, and you get the proteins, the globulins. If you want to know what's in the globulins, then you have to do electrophoresis. And electrophoresis is simply separating proteins in an electrical field. They move at different rates, so they will separate out into globs of antibodies, globs of transfer or transport proteins, so that you can measure them and you can identify them. It's time consuming. Some insurance companies don't like to cover it, but what you get in electrophoresis is an explanation of what that total globulin means to you. I have a cold. I'm going to have an increase in almost all of them because I've got an immune response going on. I have I have one blob that's twice as big as the other. Well, then your physician's going to have to figure out, is that because you have allergies? Is that because you have a monoclonal disorder or whatever it happens to be? That glob separation gives you the amounts of globulins that are present.
Thanks,
Okay.
Susan. I think in the interest of time and our other speakers, we're going to move on, but really appreciate you showing up. Even though we know that you're wearing your hospital pajamas below your waist. Yeah.
Listen, I got this now, so be careful what you say.
Have a good day.
Thank you very much, and to you as well. And Dick Silva, I hope you like the Max Wintro picture.
Okay. So, as I earlier introduced, Dr. Gowan will come and speak with us about complementary medicine.